Hello, this is the lecture on the appendicular skeleton, pelvic girdle, and lower limbs. So this is the lecture on the appendicular skeletal muscles, the pelvic girdle, and the lower limb. Here's the learning objectives, and here is the list of muscles to memorize. They are organized by muscles that move the thigh or act on the hip joint, muscles that move the leg, which remember is the lower leg or the calf area, or you can describe that as muscles that act on the knee joint. Then muscles that move the foot and the toes, they act on the ankle, foot, and toe joints. And I would like if you would try when you're learning these to organize them into groups and memorize them in groups because it will help you a lot in memorizing them. I think you know what I mean. I've talked about this before. Just try to keep it all nicely sorted in your mind. Okay, this is the drawing assignment, gluteal group and the lateral rotator group, then the gluteal group and the lateral rotator group dissected, then the iliopsoas group and the adductor group, and the lateral rotator group. A bit, not very much, actually. And so we're ready. So the appendicular skeletal muscles, the pelvic girdle, and the lower limbs. There are two major groups of appendicular skeletal muscles, and they are the pectoral girdle and the upper limbs, and the pelvic girdle and the lower limbs. The pectoral girdle and the upper limbs have a large range of motion, and the pelvic girdle and the legs are larger and stronger, but they have a smaller range of motion. The attachments between the axial skeleton and the pelvic girdle allow very little movement. These muscles are important for walking, obviously an important skill. So let us embark. All right, so the muscles that move the pelvic girdle and lower limbs are classified by their actions. They move the thigh or act on the hip joint, move the leg or act on the knee joint, move the foot and toes, extrinsic group and intrinsic group, and act on the ankle, feet, and toe joints. A little bit different ways to describe them. Okay, now to review, during development of an embryo, the leg rotates medially at the knee. Due to this, flexion of the knee joint is a posterior movement, and extension of the knee joint is an anterior movement, both considered in the sagittal plane. So flexion, posterior movement, sagittal plane, extension, anterior movement in the sagittal plane. The anterior of the thigh contains the muscles that extend the knee joint, like the quadricep group. The posterior of the thigh contains the muscles that flex the knee joint, like the hamstring group. And here I have on the side the little picture of the baby who is having its leg rotating medially at the knee at about 7 weeks. And therefore, from the knee down to the ankles and toes, flexion is a posterior movement. And this is not just a human thing. The limbs of other mammals have the same arrangement. And I have here the skeleton of a shrew showing that the lower limbs flex to the posterior, just like our knees, just like our limbs. Okay, so starting with 4 groups of muscles that move the thigh or act on the hip joint, they are the iliopsoas group, which contains the iliacus and psoas major muscles, the gluteal group, which contains the gluteus maximus, the gluteus medius, and the gluteus minimus, and the tensor fasciae latae, not to be confused with the iliotibial band. That's an easy one to make a mistake on. This is a muscle, tensor fasciae latae. The lateral group contains the obturator externus and the obturator internus, the piriformis, the gemelli, superior and inferior, and the quadratus femoris. The adductor group contains the adductor brevis, the adductor longus, the adductor magnus, the pectineus, and the gracilis. So this is a picture showing the iliopsoas group, the gluteal group, the lateral rotator group, and the adductor group. And here is a picture of a real cadaver dissection, sagittal section on the left, coronal section on the right. The muscles that we are particularly interested in are the ones in the red boxes, and you can go through them and look at them, and it is interesting to see. Okay, so the appendicular skeleton, the iliopsoas group, and the gluteal group. I will talk about them in this next little block. There's our list again. Okay, so we're working on the side over here to the far left. Okay, all right, so let's start with the iliopsoas. The iliopsoas is the most powerful flexor of the hip joint. It has two parts. It has the iliacus, which originates in the fossa of the ilium and inserts on the lesser trochanter of the femur. The action is flexion of the hip joint. The psoas major has a very different origin. It originates on the vertebrae T12 to L5 anteriorly. The insertion is the same. It's the femur, the lesser trochanter. The action is flexion of the hip and also flexion of the lumbar vertebral column. Okay, moving on to the gluteal group. The gluteal muscles are in three layers. The gluteus maximus is the most superficial. It is the most powerful hip extensor. The gluteus medius is intermediate. The gluteus minimus is deepest. And it might be helpful to think that the medius is intermediate to help you to know where to expect the gluteus minimus. The gluteus maximus originates on the ilium, the sacrum, the coccyx, and the thoracolumbar fascia. The insertion is on the iliotibial tract and the femur. All of the fibers of the gluteus maximus perform extension and lateral rotation of the hip joint. In addition, all of the fibers help the iliotibial tract stabilize the extended knee. The superior fibers abduct the hip joint, and the inferior fibers adduct the hip joint. So that's interesting. I mentioned thoracolumbar fascia. What is it? It is a large diamond-shaped area of connective tissue that surrounds the intrinsic back muscles, including the erector spinae and the quadratus lumborum. It's an attachment site for several muscles, for the trapezius, the latissimus dorsi, and the gluteus maximus. So here's a nice picture in cross-section showing the thoracolumbar fascia surrounding the intrinsic back muscles. The blue are the erector spinae muscles, and the green is the quadratus lumborum. And then the picture that shows a posterior view, well, it's pretty clear. It's showing the diamond-shaped area of connective tissue, and it's clear what the thoracolumbar fascia looks like. Okay, the iliotibial tract or band is a long stretch of collagen fibers on the lateral thigh. It extends from the ilium to the tibia, and I mentioned that for the gluteus maximus, the insertion is the iliotibial tract and the femur. So now we're finding out about what is the iliotibial tract. So the gluteus maximus and the tensor fascia latae anteriorly both insert on the iliotibial tract, and when they contract, they pull on the tract. The iliotibial tract stabilizes the lateral knee joint. So it has these two muscles, the gigantic gluteus maximus and the tensor fascia latae, attaching superiorly, and when they contract, pulling strongly on the iliotibial tract and stabilizing the lateral knee joint. Okay, moving on to the gluteus medius and minimus. The origin of the medius is the iliac crest and the lateral ilium. The origin of the minimus is also the lateral ilium. The insertion is the femur, the greater trochanter. The action on the hip joint is abduction. The anterior fibers perform medial rotation of the hip joint, and the posterior fibers perform lateral rotation of the hip joint. These muscles stabilize the pelvis when the opposite leg is off the ground, as in walking. Okay, now the tensor fascia latae muscle. The origin is the iliac crest and the anterior superior iliac spine. That, remember, is the most anterior point of the iliac crest. The insertion is the iliotibial tract. On the hip joint, it performs abduction and medial rotation. And at the knee joint, it helps to extend and laterally rotate the knee. And here's a picture of the right pelvis with origins, showing us the gluteus medius is superior to the gluteus minimus. The gluteus medius is also superficial to the gluteus minimus. Then we see the origin of the gluteus maximus, which remember was spread out over the ilium, the sacrum, the coccyx, several spots. Then we have anteriorly a small area where the tensor fasciae latae is inserting. All right, and there's a table from Martini's. Okay, moving on, the lateral rotator group. There are 6 lateral rotators that are deep to the gluteus maximus. They originate on different areas of the sacrum, the ischium, and the pubis. And here's a list for us to go over of where they originate. So the piriformis originates on the anterolateral sacrum. And if you're listening to this, I hope that you can look at the pictures to help yourself, or it's hard to really imagine. So the piriformis, origin, anterolateral sacrum. The gemellus superior, origin, the ischial spine. Gemellus inferior, origin, ischial tuberosity. The obturator internus, origin, medial obturator foramen and medial surface of obturator membrane. This is difficult to visualize. I recommend looking at a skeleton and imagining where the muscle would run. The obturator externus, the origin is the lateral obturator foramen and lateral obturator membrane. And finally, the quadratus femoris, the origin is the ischial tuberosity, the lateral side. Okay, now on to the lateral rotator group insertions and actions. The lateral rotators insert close to one another on the greater trochanter and a little bit going down from the greater trochanter to the posterior femur. Their actions are lateral rotation, no surprise because it's the lateral rotator group, and abduction of the hip. The quadratus femorum is the most inferior one of these lateral rotator muscles, and it only performs lateral rotation. It cannot perform abduction of the hip in the position that it is in. Clinical correlation, piriformis syndrome and sciatica. The piriformis, the most superior lateral rotator, lies over the sciatic nerve, which is the longest and thickest nerve in the body. It's something around the size of like a shoelace string. Okay, like an old-fashioned shoelace on an old-fashioned sneaker, to give you an idea of the size. It's quite big and thick. It is thought that the piriformis muscle may become inflamed due to overuse, prolonged sitting or standing, and/or trauma. The piriformis muscle becomes inflamed and compresses and irritates the sciatic nerve. It leads to pain, tingling, and numbness in the buttock that radiates down the leg if it gets worse. This condition is known as sciatica. Okay, next group, the adductor group. Okay, so different muscles of the thigh are found in different compartments that are separated by intermuscular septa, and the adductors are in a compartment that is located medially and a little bit posteriorly, but in general, it's called the medial compartment. And in this picture, we again see in blue, the adductors are in the medial compartment, and we see the adductor longus, the adductor brevis, the adductor magnus, and the gracilis. The adductors originate on the pubis and ischium, and they cover a lot of ground. So going from the most superior and anterior to the most inferior and posterior, we have the pectineus, which originates on the pubis, the superior anterior ramus of the pubis. So the pectineus lies between the iliopsoas and the adductor longus. The adductor longus originates on the pubis, the body. So we're going from the anterior superior ramus and we're traveling medially and we get to the pubis body. And then the gracilis, the origin is the pubis, the inferior ramus. Adductor brevis, the origin is the pubis, body, and inferior ramus. And the adductor magnus, origin is the pubis, inferior ramus, and the ischial tuberosity. So we've made our way around the obturator foramen, and now we're all the way to the ischial tuberosity. All of the adductors insert on the posterior femur in the linea aspera, but also other points. The action is adduction and flexion of the hip joint. It's no surprise that the adductors perform adduction, but perhaps it is a little bit of a surprise to you that the adductors can perform flexion. And in the next slide, I will show you the positions of the bones and why it makes sense that that is one of the actions of this group, in why adduction and flexion are the two actions of this group. Okay, the gracilis is an exception to the above, and I'll have a slide on that. In addition, the adductor longus and the anterior adductor magnus medially rotate the hip joint, and the posterior adductor magnus extends the hip joint. Okay, so here's the look at the relative positions of the hip bone and the femur. And this helps to show us how the origins and the insertions of the adductors lead to their actions. Takes a little bit of imagination, but you're going around from the superior ramus down through the body of the ramus, then to the inferior ramus, and finally all the way to the ischium. So these groups have variable insertions and end up performing different actions depending on their location. If they're anterior, they'll form flexion, etc., like we learned with the arms. The gracilis has a different insertion and several different actions than the other adductors. So the gracilis has an origin on the pubis, the inferior ramus, and an insertion on the medial tibia. Because it crosses two joints, we can say that at the hip joint, it causes adduction and medial rotation, and at the knee joint, it causes flexion and medial rotation. I think of this how you would be standing if you had contracted gracilis, and I think of a position as though you were trying not to pee, with your hip joints adducted and medially rotated, and your knee joint flexed and medially rotated. Okay, here's a summary slide. The muscles that move the thigh flex and extend, adduct and adduct, and medially and laterally rotate the hip joint. And this is a slide from Martini's, where they're showing you the lines of action by showing you these white arrows. And it's kind of interesting to me. All right, so there's a list of your muscles. And